Hi, everybody. I'm April Cummings, and joining me right now is Dr. Anita Johnson from Cancer Treatment Centers of America. And she's kindly agreed to talk to us today about issues related to breast cancer. Thank you so much for being here.
Thank you for having me.
Let's talk a little bit about the subject at hand. What do you think is important for people to know?
What's most important about breast cancer is that breast cancer treatment has evolved. About when I started being a breast surgeon about 20 years ago, most women were having mastectomies. So what we know today is that when you have disease in only one part of your breast, that you're a great candidate to keep your breast. And so we offer women lumpectomies. With the addition of radiation therapy, we know that it is equal to you having a mastectomy. So treatment guidelines have changed. Not all women need to have chemotherapy. Those that do, we really work hard on treating the side effects.
So some of the prior treatments may have scared people away sometimes, just from even finding out where they stood health-wise. Do you think that this will help people maybe come forward more earlier?
That is my hope. The more that women are informed, that's why we encourage them to get their mammograms at the appropriate age, which is 40 years old, because early detection counts. If you're detected at an earlier stage, you have better options in most cases. In some cases, we're able to do all of the treatment, the majority of the treatment in one day. Some women, they can get a lumpectomy. If their lymph nodes are negative at the time of surgery, we actually do the radiation then and there on the table. And it does, depend on their tumor profile, but those are some of the changes that have come about in the recent years.
So maybe less fear.
Less fear.
Greater opportunity to just come in the room earlier and get seen.
And that is very important. Continue to do your breast exams. I'm a huge believer of that. Most women who are diagnosed with breast cancer, they actually discover their own lump. So I still encourage you to do your monthly breast exams.
What else do you think it's important for people to know about kind of where we are, what the right things are to do at this stage?
One thing is, just know your body and know your family history is important. Most women who have breast cancer actually don't have a family history, but those who have a strong family history of breast, ovarian cancer, or prostate cancer, they're predisposed to being at higher risk for breast cancer.
So one of the reasons that you're here actually is to work with some of the medical professionals in Cayman and sort of bring them, kind of up to speed with what some of the changes are that have been going on. What kinds of things did you share with them?
As far as I am a breast cancer surgeon, so what has come about, over the past decade is that the surgical options have changed. We work closely trying to get a great cosmetic outcome as well as making our patients cancer free. So the term for that is oncoplastic surgery. Say for instance, a patient is having a lumpectomy. Sometimes we can offer them a hidden scar type of surgery. If they're in need of a mastectomy, some patients, not all, can have what we call a total skin sparing mastectomy, where we keep all the skin, including the nipple, and then the plastic surgeon comes in and performs the reconstruction.
How important in your view is it it just seems like not too long ago the cosmetic component of this wasn't considered as important.
Right.
But to the psyche,
Right.
I would
It's
want...
very important.
Yeah.
It's very important for me, for my patients, but for me as a woman surgeon, it makes me feel better at the end of the case, that it's nice, that I know when she looks in the mirror that she'll be comfortable. Because one of the greatest fears is not just having breast cancer, but being disfigured. Several decades ago, women went with mastectomies without reconstruction. Some still walk in today without even a prosthesis. And most patients today can have reconstruction done at the same time of surgery after their mastectomy.
I mean, not that anything makes it easier, but
Right.
I can see that that might improve also how you feel afterwards.
Exactly.
And help you focus more on healing
Exactly.
and less on sort of that emotional strain.
Exactly.
Thank you so much for talking with us. Is there anything else you want to share with folks before we go?
As I discussed, know your family history. Breast cancer treatment actually starts just knowing your family history, knowing if you're high risk or not. At our facility, we offer, genetic testing, which is important, as well as we screen women to see if they're high risk. So get your mammograms starting at the age of 40 and every year after that.
Thank you so much for talking to us.
Thank you.
I'm April Cummings, and our focus is lung cancer. We're talking with Dr. Dennis Tishko from Broward Health International. Thank you for joining us.
Glad to do it.
This is not the topic that we hear quite so much about these days. Why is that?
That is a really good question. And it's a good question for a lot of different reasons, but especially because lung cancer is a huge problem, much more than many people know. And the fact that we don't know much about it and it doesn't get talked about very much is really disturbing, but this is a wonderful opportunity, so thank you.
So let's talk a little bit about what people need to know. It's a bigger problem than most people realize. What can be done? What can we do?
You're right, it is a massive problem. And the magnitude of that problem is something that a lot of people are really shocked by. Lung cancer is overwhelmingly the #1 cancer killer in the country, in the United States. And we know this year cancer is now the leading cause of death in the United States. So this is really something that should be a target. Lung cancer is killing about 170,000 people a year. And what that means is it's killing 4 times as many people as breast cancer. It's killing 28 times as many people as HIV and AIDS. But yet it's a topic nobody talks about. There's no public interest in it. There's no public forum. But it is so large that it's hard to imagine someone or a family that hasn't been touched by it.
In some way. So what do you want people to know? It is a bigger problem than most people realize, but if you are touched by it in some way, what can you do?
The first thing to realize is that it's a topic, it's a disease that we can approach. And it's a disease that has excellent results if caught early. So for many years, for decades, we've been hoping to have a screening test, some way to check for lung cancer. And a few years ago, that was actually determined. A high-speed, low-dose CT scan, a CAT scan, that doesn't use contrast, so there's no IV, no needles, it's painless. And when we say fast, it's a high-speed 4-second scan that can really save lives. And the results from that are pretty remarkable. What we can see in the latest trial is people who've smoked, high-risk individuals who've smoked, who have the CT scan, have a 71% 5-year survival. People who are not scanned have a 19% survival. So the benefits of doing the CT scan are really massive, and considering how easy the scan is, it's remarkable that we're just not scanning as many people as we want. In the United States, we're only barely scanning 2% of the people. So that gives us a huge opportunity to do remarkably good work.
So screening like this is really important.
It's absolutely vital, and it's the only way we have to catch this disease early. There is no blood test for lung cancer. No matter what you read or hear about, there is no blood test for lung cancer. The only way to catch it early is with a quick CT scan. So getting that message out, and even if people don't smoke themselves, if they've never smoked a day in their life, chances are they know somebody who has. There's a family member, somebody they love, somebody they care about, really needs to know about this. So even if the information doesn't directly affect you, it probably affects somebody you care about.
So this is not particularly invasive, not invasive at all.
Not invasive at all.
It's easy to do. The big issue is just making sure that more people know that it's out there, and that by taking advantage of this, you really can improve your survival rates incredibly.
Exactly. And what we see when the lung cancers are caught early is that we can do something about them. And the thing to do is get the cancer out. So for many years, we've been seeing cancers coming in later and later. Those are very difficult to treat. But cancers caught early, small cancers, when they're removed surgically, long-term results are excellent. 95, 100% 5-year survivals. When we talk about cancer, we talk about 5-year survivals, just because that's a convenient time to sort of standardize against. But seeing 95 or 100% 5-year survivals, I think really surprises people. They may not know that an early stage lung cancer can be cured with surgery. And that's really grounds for optimism. People should be saying we have a bad problem that has an excellent treatment if caught early.
So I'm going to throw one last one at you because there's been so much talk about vaping lately, and there's the Centers for Disease Control are doing an investigation. Do you have any thoughts on that, on what you're seeing right now?
Yes, and we have to separate out what we mean by trouble. We know for lung cancer it takes 20 years for a cancer to develop. So when we're talking about vaping, which is a pretty brand new topic, we can't really speak with the history that we have for something like lung cancer. But we know clearly that combustion, burning things, produce chemicals that cause cancer. That's really pretty much the mechanism with smoking, is the burning material creates the chemicals that cause the cancer. And vaping is basically burning material that you're inhaling. So it's not much of a scientific stretch to say combustion in any form is bad for lungs. What we're seeing at the CDC are actually pneumonias and inflammatory changes in the lungs. But I think it is a very ominous thing to see this early in a product. So there is no safe vaping. There is no safe product. And no matter what you want it to be, it's a bad and dangerous idea. Seeing this much disease this fast should get everybody's attention.
Thank you so much for talking with us.
Glad to do it. Thank you for having me.
I'm joined by Dr. Arun Nagarajan with Cleveland Clinic Foundation, and the topic that we're going to be discussing is rectal cancer. Thank you so much for being here, and thank you for visiting us here in the Cayman Islands and bringing your expertise to the people.
I appreciate the opportunity. It's fantastic to be here. Wonderful island. I've been on a ship before, but not on an island before.
So now you're getting the full Cayman
Yeah, I'm
experience.
just going to walk around and explore. I plan to walk to the mall in the evening.
Oh, good.
It's a beautiful area.
Yeah. Well, we're really glad to have you
Nice.
here. And as you know, when you're in an island in the Caribbean, we don't always have access to this type of expertise.
Right.
So I think we're grateful for this and for the symposium and the information you're able to share, both with the healthcare
pleasure.
experts and with the community. So I mentioned we're discussing rectal cancer. Can you tell us a little bit about, because I think there might be, sometimes you hear the term colorectal cancer,
Right.
or can you just kind of describe the differences between these?
Yeah, I think that's a very good, important question. So when you look at the bottom of the opening, that's the anal canal, which is about 4 centimeters. And from 4 centimeters onwards, upwards to about 15 centimeters, the rectum. It's really important. The anal canal is squamous cancer. But the rectal cancer is adenocarcinoma. There's some interchangeability, but for the most part, squamous anal and rectum is adenocarcinoma from the 4 centimeter to 15 centimeter. And above 15 centimeter is the colon, the sigmoid colon. So the location becomes really important, because for rectal cancer, one of the treatment strategies is radiation therapy for
Right.
local control. But for colon cancer, we don't use radiation therapy.
It would be a
Right.
different treatment, so it's
Right.
important to know.
So bottom to about 15 centimeter, and the rectum is divided into low, mid, and upper, 3 areas. And the location is also important, because low rectal tumors have a different outcome. They're more aggressive, and in terms of surgery, they may need a permanent stoma ostomy bag
Okay.
when it's really low, where they cannot really hook up the remainder of the rectum.
Okay.
So location becomes important.
And what's the prevalence?
That's a great question. I was looking at the data yesterday in anticipation that this may be a question. In the US, is about 150,000 new cases per year. And I think the rectal cancer has overtaken colon cancer. More new rectal cancer, about 50 to 60,000 per year. And the rates of new rectal cancer is going up in rectal as opposed to colon. And also more in younger patients than older patients.
Okay, so I saw actually something on that, I think it was on 60 Minutes maybe,
Right.
talking about it with the younger patients. So why do we think that is?
Well, I think it's complex. When you look at the genetic factor, it's only about 10-15% at the most. But majority of it is, lack of exercise, obesity, and really unhealthy food habits, unhealthy processed foods. Even the World Health Organization now classifies red meat as a risk factor. Right, WHO says red meat is a risk factor for colorectal cancer, and I personally don't eat red meat. I like to eat lamb here and there, but I try not to overdo it. And I tell my patients not to, grill the meat. I think there may be some carcinogens released when you grill the meat. So it may be relevant to folks who live here,
Okay.
where meat is a big part of their diet, I understand. So I think switching over to fruits and vegetables and exercise and controlling body weight is really important.
So major lifestyle factors
Major
then
factors,
in this
right.
case. Is there any type of like regular screening that people should get, or what do people need to be aware of?
So everybody should start, the US national guidelines allows people to get a colonoscopy at 45 now. At 45,
Okay, it
right?
used to be
It used to be
50,
50,
right?
so
Okay.
they moved it to 45.
Okay.
Some insurance, I think they give a pushback, but I think doing colonoscopy at 45 is not unreasonable. And if you have a family history, you can even start as early as 40. If you have a family history, let's say somebody has a colon cancer diagnosed at 51, their family members can get screened at early 40s. And then if you have syndromes like Lynch syndrome, it's a genetic syndrome. If the families test positive for it, you can even start screening at the age of 21. That's the national
Okay.
guidelines. So there's a lot of importance towards screening in this disease.
Okay, so 45 then for screening. When you talk about family history, if say you have a close family member who maybe hasn't had a cancer diagnosis but have had maybe multiple polyps have had to be removed, is there a chance that you might?
No, I think it's really
that-
complex. As I said,
Okay.
the risk of genetic predisposition is not high. It's about 10%, 10-15%. 85% of the colorectal cancer in the US and probably here is all sporadic, meaning environmental.
Okay, and what are the outcomes now in terms of treatment and?
Yes, generally speaking, the outcomes for all cancers have improved when you look at the national database, and outcomes for colorectal also is improving. But I think the key is prevention. We are not doing enough to prevent this in the first place. We were talking earlier about HPV in anal cancer and oral cancer, but there's no prevention in here. I think prevention is lifestyle change, and that may take 20 years to see.
Okay. Thank you so much for sharing this information with us. I think, the big message here is really
Right.
look at what you're doing, look at what you're eating.
Look at what you're
exercise.
eating, exercise, obesity control, and really can go wrong with fruits and vegetables. And I'm a big proponent of organic foods.
Okay.
If there is available, bioorganic, I think pesticides, water, they may all play a role in this. These are all unanswered questions.
And if it's in a box, maybe don't eat it.
Exactly, right. I think processed foods, even simple things like cheese is heavily processed. Even ice cream is heavily processed.
Okay.
They're all ultra processed foods. If you Google ultra processed foods, you may get a list of things you may want to avoid.
And those are the things.
I mean, you can't avoid all of it, but I think it's important to pay attention to these things.
And if you are having those things, moderation.
Moderation,
Right?
exactly.
Okay.
Yeah, absolutely. You may still get it, but at least you've given yourself a chance.
Okay. All right. Dr. Nagarajan, thank you so much
Nice to
for
meet you.
joining
Thank
us.
you. Thank you.
Hi, everybody. I'm April Cummings, and we're going to be talking about an interesting subject today with Dr. Cesar Perez. He is from UHealth, University of Miami Health System. Thank you so much for joining us today.
Thank you very much. Nice to be here.
So, when we talk about HPV normally, we're so conditioned right now to think about cervical cancer, for example. But you're here to tell us that there's more going on than that.
Yes, HPV, so it's the human papilloma virus, and it's a virus that is associated with cervical cancer. And we know that we have pre-malignant lesions, so we can detect lesions that are precancerous lesions in the cervix with pap smears. And we know for the last 40 years we have been doing pap smears to try to catch it early and try to prevent cervical cancer. The truth is that HPV is associated with 6 different cancers in total, including penile cancer, vulval cancer, anal cancer, cervical cancer, and also the head and neck cancer, so cancer to the oropharynx. Right? And the problem with cancers from the head and neck that are associated with HPV is that they don't have these pre-malignant lesions that we can screen, so we can prevent the cancer. And that's something we have been, over the last 20 years, cervical cancer has been decreasing in incidence because we're usually catching early the pre-malignant lesions. However, we found that head and neck cancer that is associated with it has actually been increasing in incidence for the last 30 years. And that's when we actually discovered the association 12 years ago with the HPV virus.
So that makes for a challenge, certainly.
It is a challenge and it is a problem because it's becoming an epidemic. And in EU Health, we have an extensive preventive program in trying not only to try to detect cancer early, but also our preventive trying to vaccinate and extend our vaccination throughout Florida. We have South Florida has a territory of 6 million, and our population that we have to cover is at least half of that. Head and neck cancer in 2020, so next year, it will actually surpass in incidence, HPV-related head and neck cancer will surpass cervical cancer in incidence next year. So obviously it's becoming an epidemic now. And the only preventive measure we'll actually have is the HPV vaccine.
So at the core, the idea is that really people need to know that there's not just one reason to have this vaccine.
There's not just one reason, and also we have to know that usually we focus the HPV relationship with women. But truly, the HPV-related head and neck cancer is more prevalent in men. So it's also a problem for women, of course, but the whole HPV compendium of associated cancer that in US is calculated to be 35,000 cases every year of HPV-related cancers. And of those 35,000 patients, at least 1/3 of them will die from their disease, even in this developed country. Truly, we can potentially prevent in US at least 10,000 deaths per year of HPV-related cancers, of which some of them are cervical cancer, but not most of them. Many other, including anal cancer, penile cancer, and head and neck cancer, are actually are not what we usually think about when we think about HPV.
So that is really your core message, is that there's this other aspect that we're not paying attention to, but is an equally important reason to get the vaccine.
Yeah, and equally important, actually increasing now in incidence. Actually, the trend is going on. We have an HPV epidemic, and HPV has been one of the extensive studies that we have been doing, and one of the focus that we have at UHealth, trying to focus and study the virus. And obviously, when patients develop the cancer, we are in the forefront of developing immunotherapies to try to cure more patients, right? And one of the many reasons why we have been NCI designated now, and we're the one of 2 programs that is NCI designated, by the National Cancer Institute in the state of Florida, and the only province of Florida, because we have been focusing in the treatment for the HPV, but now we are looking back and we have to focus more on the prevention of the disease, and we're hoping that by 2030, at least in US, 80% of the young adults will have been vaccinated, and that's a WHO goal. So we're hoping to reach that goal with these programs.
Thank you so much for your time. I really appreciate that.
Thank you so much thank you for your interview. It has been a pleasure.
Dr. Perez Mitchell is with us now. He's with the Memorial Healthcare System, and he's going to be talking about robotics in head and neck surgery. But first, I'm going to learn a little bit about his history. Thank you so much for joining us, and thank you for being in the Cayman Islands.
Oh, thank you for having me here. It's a pleasure.
So I must be honest, I read your bio, and you have an interesting story. How did you decide to become a doctor? Why was that important to you?
Well, I think one of the main reasons in my life that made me think about the career of medicine was sickness of my father, who passed away. I noticed and I realized that medicine and specifically the medical doctor is extremely important in the worst or the lowest, if you may, part of a family who's losing a loved one. And I wanted to make sure that I was able to take care of not only of my family, but specifically of people that are having cancer. And that's basically the reason why I came into medicine.
And so you got into the surgical side of things, but then decided to specialize in cancer. How did your experiences impact your approach with your patients?
That's a great question. You know, ENT is a very broad specialty, has to do with diseases of the ear, nose, and throat. Most people know it as otolaryngology, basically. So we deal with head and neck diseases. Specifically, I deal with cancers of the throat area, the tongue area, neck area. I'm originally from Puerto Rico, also an island on the Caribbean. And at the time, there was a dire need for those services which were not available on the island. I'm sure, you know, it probably happens here on the Cayman Islands where sometimes you need to fly abroad for services that are extremely specialized. So I had to fly out from Puerto Rico to the mainland U.S. to do my training, specifically in cancers of the head and neck, in order to be able to help my people. Basically, that's what it was.
A lot of what some of the feedback has been from your patients is that you treat them like family. Did your experiences with your father really make you think about the way you connect with your patients?
Absolutely, absolutely. I had two experiences with my father and my fiance. My fiance passed away of brain cancer, so definitely God had a plan for me, and I think that I listened well. I think my God-given talent to be able to operate on cancers of the head and neck, I definitely have a calling for it. And I think that for me, the battle against cancer, and I always say this, is it's personal.
Are we making progress then, do you think?
Absolutely, absolutely. Cancers of the head and neck used to be very mutilating, meaning that, it affects areas like the swallowing, speech, breathing. A lot of patients wind up with tracheostomies, which are tubes that we put on the neck for breathing. And advances have been so good that now we're able to do major surgeries or remove cancers of hard to reach areas without having to affect those regions. So quality of life definitely has been improved.
Now, tell me, how is robotics changing this? What is the specific role that robotic surgery is making a difference?
So in order, you can imagine a cancer of the throat, which is what we see most commonly now, and I may add, if you allow me, that throat cancers that are related to the human papillomavirus are actually the most common cancers related to that virus that used to be cervical cancer. So about a month ago, a paper came out stating that has surpassed throat cancers related to this virus, has surpassed cervical cancer. So that means that we're seeing an increase in the incidence of this cancer. We needed to make sure we have ways and means to try to minimize the morbidity entailed by the treatment. So that's how robotic surgery came about. You can imagine that the surgeon's hands do not fit through the mouth into the throat. So we started using the robotic system. It's called Da Vinci system, which is also used in urology, so using gynecology surgery. So now we can we have access through the mouth into the throat without having to do major splitting of the jaw or major splitting of the neck. Way faster, recovery times are way faster. Patients stay in the hospital 3 days instead of 7 to 10 days. Patients can go home with oral feeds. They used to go home with gastrostomy tubes for feeds, and they also needed tracheostomies for breathing. Now you don't need tracheostomies. So it definitely has allowed us to be less traumatic if you may with the treatment without compromising the oncological outcomes, which at the end of the day, that's what we're looking
That's what
for.
you're trying to do,
Yeah.
right? So that's really interesting what you were saying about the HPV virus and the throat cancer, because when you think about it, I mean, most women go for regular gynecological screenings. Is anybody screening for this, or how do we?
You know, the sad part is that we do not have a screening tool for cancers of the throat. We have it for colon, we do colonoscopies, prostate exams, mammography for breast. So I always liked, in these forums, I always like to enforce the fact that the only way we can screen is to be aware of the early signs of the disease. So I always like to say that we have to look for things like a aphthous ulcer of the tongue that doesn't heal in 2 weeks, any throat pain that doesn't get better in 2 weeks, or any hoarseness that doesn't improve in 2 weeks that needs someone to take a look at. Would it be a specialist? Would it be your primary doctor? But someone needs to take a closer look at what's going on. That's really what we have right now.
So it's just don't ignore those warning signs.
Correct. I also want to add that the vaccine for the HPV, it's out. The age has increased to 45 years old. The age used to be only to like 21 years old.
Oh, that's interesting.
About, I want to say maybe about 3 months ago, it increased so we can vaccinate. The FDA approved it for vaccination up to 45 years old. So that's something extremely important for people to know as well, because it could definitely be protective.
And that's for men and women.
Men and women.
Okay.
Human papillomavirus is the most common sexually transmitted disease in the world. Estimates show that about 80% of the US population is infected with the virus. Most patients are asymptomatic, because even if you get infected, the body has a way to get rid of it most of the time. The problem we're having is that there's about 100 strains or more of the virus, and specifically number 16 is the one that's causing throat cancers. So again, I think the prevention vaccination is extremely important. I think it's a hot topic, and I think a lot of people are afraid of vaccinating their children, but I mean, I see these cancers every week, correct? So yes, and I really think that everyone should be getting this vaccine. I really recommend it.
Okay. Dr. Perez-Mitchell, thank you so much for sharing this information with us and for sharing the good news with what you're able to do with robotics now.
Thank you. Thank you. Appreciate it.
Thank you. We're talking to Dr. Rupesh Kotecha with the Miami Cancer Institute, which is part of the Baptist Health South Florida system. And we're talking about the new age of personalized radiotherapy. Thank you so much for being here. Thank you for coming to the Cayman Islands and sharing your expertise with everyone here.
Well, thanks for having me. This is my first time here, and it's been absolutely wonderful.
Good. We hope you come back then, too. When we talk about personalized radiotherapy, that sounds a little, I would have never seen that coming, I guess. So can you tell me a little bit about what that means in terms of, how you're able to actually create something that is specific for a patient's needs?
That's a great question. So now we're really entering an area of cancer care where we personalize treatment options for every patient based on their specific risk factors, their specific characteristics, potentially any mutations they may have in their cancer, and really the extent of their disease. And when people think about personalized cancer care, they traditionally think about medical oncology. There may be certain mutations in their cancer, and then they could receive a targeted drug for their specific cancer and a specific molecular alteration in their tumor. However, in radiation oncology, we've made similar types of advances. And although we don't treat patients based on specific mutations or molecular alterations, that information is actually essential for how we make decisions in radiation oncology. And they could be as simple as we should combine forms of radiation with some targeted agents. Potentially, if patients progress on targeted therapy, instead of changing to a different type of targeted therapy, we can actually just radiate that area that's growing past that molecular alteration, and that patient can actually stay on that targeted therapy. And then finally, we can actually personalize the actual type of radiation that we give to a patient. So radiation therapy is traditionally a black box. And unfortunately, patients may not know what type of radiation they're getting. We use different particles of radiation to actually treat patients. Historically, there were electrons and photons. But now we have different types of particles, for example, protons. So we're able to offer proton therapy for a variety of patients. But even if I just said, this type of radiation, photon therapy, is available for a majority of patients that are treated either in the islands or in the US or across the world. All types of photon therapy are really not the same. There's a variety of radiation technologies that are available to treat cancer patients. And when a patient is newly diagnosed with a certain type of tumor, they traditionally see a radiation oncologist and they're told, okay, this is what you have, this is the type of radiation that you need. We will scan you tomorrow, and then you will start on Monday. However, the actual type of radiation that the patient may receive, they may not know. And it may not be personalized to them. It may be based on the only machine that's available at that cancer center, and the patient's not given that information. Contrary to that, at our cancer center, we're very fortunate in that we have basically one of every single machine they make in radiation oncology. So when I see a cancer patient, I'm able to make a personalized decision for that patient and choose that machine which is actually best for them based on all of those factors. Any mutations, patient characteristics, risk factors, and disease extent. And therefore I'm able to offer that patient the best form of therapy for that particular patient. And it may differ from the very next patient that I see in clinic that may be very similar, but actually has specific differences in which I have to choose a different machine for that patient.
So I think one of the things that you mentioned is, you get the diagnosis, we're going to scan, we're going to start radiation. There's a lot of information, I think, coming at someone who receives a cancer diagnosis. It can be intimidating, overwhelming, you feel the need to just trust your doctor and do what they say. How can a patient be their own advocate? What questions should they ask? What things should they be aware of?
That's a great question. Whenever you're diagnosed with a cancer, the first thing that you should do is make sure that your case is presented at a multidisciplinary tumor conference. Okay? This is something that we do for a majority of patients that are seen at our cancer center. And this helps to ensure that the patient is treated on a specific care path or pathway that is based on that patient's disease extent and based on the current standard of care for that patient and potentially any clinical trials that may be offered for that patient. So for example, I primarily specialize in brain cancer and in lung cancer. So when we have a patient who's newly diagnosed with, for example, a stage 3 lung cancer, that's very overwhelming for the patient. You hear stage 1, stage 2, stage 3, and stage 4. And everybody knows that stage 4 disease is where you don't want to be. And if you are at stage 3, that's very concerning to you. You know that's close to 4. Well, there's a variety of treatment options for patients who have stage 3 lung cancer. You could sometimes get chemotherapy followed by surgery and then maybe radiation therapy afterwards. Some patients get chemotherapy and radiation and then go to surgery. Some patients get surgery first and then get chemotherapy and radiation afterwards. And some patients get chemotherapy and radiation together and then potentially get immunotherapy afterwards. So you can think about, those are just 4 essential treatment options for a patient, and that can be very overwhelming. So the first thing that we do is we make sure that we review all of that patient information, all of their images, and together as a group with multiple radiation oncologists, with multiple surgeons, with multiple medical oncologists, even social workers, even the nurses that see the patient, all of those people are involved in the decision making for that patient so that we can make sure that we make the best decision for that patient and that we have all of the information available with all of the minds at our cancer center to be able to offer that patient a treatment option for them.
So me as a patient, I would say, who are you talking to and who's looking at my file with you?
Correct.
Right?
Correct. So, when I see a patient who's newly diagnosed, they've either seen the medical oncologist or the surgeon first, or sometimes I see them first. So I make sure that the patient is told that we have looked at your images together. This is a group decision. I'm not making this decision unilaterally. In fact, outside of the multidisciplinary setting, at our cancer center, in radiation oncology, we also have an ongoing peer review for every single patient. So if I decide this is what I would like to treat the patient with, I've talked to the entire cancer team. All of my information, my radiation treatment plan, the target volume delineation, what dose and fractionation that I decide for the patient, how many treatments they're going to get, over what length of a period of time, all that information is actually peer reviewed by other radiation oncologists in our own system. So that's also very unique to how we practice radiation oncology at our center. So there's multidisciplinary with regards to surgeons, medical oncologists, and radiation oncologists, and kind of an in-house multidisciplinary care in radiation oncology.
Okay, so you want, as a patient, you want to know that that's what's happening with your case.
Correct.
Interestingly, shift gears just a little bit. You were talking about, there's surgery and chemo. These are the things we hear: surgery, chemotherapy, radiation therapy. Now, with some early stage lung cancer, radiation therapy can actually be curative.
That's correct. So with radiation oncology, we have, as a field, made tremendous advancements in technology. And that's allowed us to really expand the use of radiation therapy. Now, traditionally, when you hear about radiation therapy for early stage lung cancer, it was for patients who would never have surgery, would never even see a surgeon for their diagnosis because they were such compromised by their pulmonary function. However, we're now expanding the use of radiation therapy in those patients. And because traditionally, people thought the cure rates, the control rates were exceedingly low compared to surgery, typically 30 or 40 or 50%. Those results are honestly terrible. And that's why radiation therapy was really a last resort for patients with early stage lung cancer. With evolving technology, we're now able to offer definitive and curative radiation therapy for early stage lung cancer in 5 treatments, 4 treatments, 3 treatments, or sometimes as short as 1 treatment. Radiation therapy, when we give it in this sense, is termed stereotactic body radiation therapy or stereotactic ablative radiotherapy. Sometimes the population will hear the terms SBRT or SABR. Those types of radiation techniques are very different from the older forms of radiation therapy. It would almost be comparing an old type of surgery where we do a midline thoracotomy and then actually take out a tumor versus sometimes a robotic or laparoscopic surgery. It's very different types of radiation. They're very precisely delivered just to the area of the tumor. And really we minimize the dose of radiation to the surrounding structures, such as the rest of the lung, or even the heart or the esophagus. By doing that type of very precise radiation, we can give very high doses of radiation that are ablative, and like I said, as short as 1 treatment of radiation, which is non-invasive. The patient does not see anything, they do not hear anything, they do not feel anything. The machine doesn't touch them at any point. They're typically on the machine for as short as 15 minutes, maybe as long as 40, 45 minutes, and a few treatments later, they're potentially controlled or cured from their early stage lung cancer. There's no incision, there's no hospitalization at all required.
That's such an amazing difference in terms of the treatment and the outcomes. Now, you mentioned earlier proton therapy, which sounds very science fiction, but how has that changed things?
Proton therapy is really the most advanced form of radiation therapy that we're able to deliver. Now, traditionally, as I mentioned, electrons or photons, they're just particles of radiation. And what we're trying to do is maximize the dose of radiation in the tumor and minimize the dose of radiation in the surrounding structures that are next to the tumor. Now, we've evolved over time to make it as precise as we can, but we're very limited to how we can do that with photon therapy. Proton therapy, as you said, sounds science fiction-y. And it's actually delivered in our center using a large cyclotron that then sends proton particles at very high energies to very large radiation machines that then deliver those proton particles to a patient's tumor. What's really exciting for us is that proton therapy allows us to deliver radiation just to a tumor and to really minimize the dose of radiation to a nearby sensitive structure as much as possible. This then allows us to give a very high dose or curative dose of radiation to the tumor, but the minimal amount of dose to that nearby sensitive structure that can cause a side effect associated with the radiation, both acute, short-term, during the radiation, shortly after the radiation, but even long-term, many years after the radiation is completed.
All right. Well, I think there's a lot of good news now coming from this area of oncology. Thank you so much for sharing with us, and thank you for your time here in the Cayman Islands. Don't forget to ask those questions of your specialists, and make sure that there is a holistic approach to your care. I think those are some really important messages that you've shared with us.
They are. Thank you for
All right.
recapping those.
Thank you. I'm joined by Dr. Vinitha Benoy from Health City, Cayman Islands, and we're going to be talking about immunotherapy. Thank you so much for being part of this and being part of this cancer symposium. First of all, can you explain what immunotherapy is?
Yeah, so we all have our immune system which protects us from various infections. I mean, we all knew that for long, and we have these antigens and antibodies in the body and that fight and get rid of bacteria, viruses and all that. And for many years we knew that there's some kind of an immune surveillance system against cancers as well. So just like a bacteria or a virus, which is a foreign body, which is detected by our immune system and sort of destroyed, the tumor cells are also surveyed or under the surveillance of the immune system, and a lot of the time we don't get cancers because of how active they are against the tumor cells. But when the cancers start growing and they get advanced, they develop ways of camouflaging themselves from the immune system. So in the last 20 years or so of research, what they have identified is that we can take off or push off the camouflage of the cancer cells, or if you activate our immune system to fight the cancer itself. So this is a modality which is quite different from the traditional ways of chemotherapy or radiation. They act by direct cell kill. So they are cell poisons, or they kill the cells, cancer cells directly. But this is a different way of fighting the cancer by making our immune system fight the cancer and kill them. So there are various modalities, but quite a few of them have come to the limelight lately, and they're blockbuster drugs in its real sense, because we find such amazing results for a lot of advanced cancers. For example, lung cancer, melanomas, advanced stage 4. They have sort of revolutionized the treatment, and now patients are living longer, unprecedented results in some advanced cancers with immunotherapy. So for 3 consecutive years, the American Society of Clinical Oncology, which is ASCO, has named immunotherapy as its cancer advance of the year. So it's a very important topic, and I think it's a good idea to let the public know, let everybody know, and that there is a new modality of treatment available, which is quite different from the traditional ones.
Well, and that's I think everybody thinks, okay, cancer, so surgery, radiation, and chemotherapy, and sometimes it was one of those, or maybe all 3 of them, or maybe a combination of 2. So this is a game changer then, the immunotherapy.
For many cancers, I would not say for all cancers or all patients. We still don't know which cancers, we're still working on it.
Okay.
But lately we have seen it work for a lot of cancers very well, and we are still trying to find out which cancers, what patient, because several times we find the same cancer, different patients, it doesn't work so good. So that's the current research, trying to find out which patient it works best for. But definitely, especially lung cancer, I would say it's a game changer. And we have been giving immunotherapy here in the Cayman Islands for 4 years about, and we see such fantastic, unexpected, maybe miraculous results in a lot of advanced cancers.
So particularly small cell lung cancer, is that right?
Both non-small and
okay.
small cell. It started
Okay.
off with non-small cells, but lately it's been approved for small cells as well.
Okay. And how has it changed the outcomes for patients who are diagnosed with that?
Yeah, so when I say advanced stage 4 non-small cell lung cancer, the 5-year survival, the possibility that somebody diagnosed today with stage 4 lung cancer will live for 5 years is less than 5%. So the first year mortality is so high, it's about 60 to 70%, and the average survival was about 9 to 12 months after a diagnosis. But when we see that patients are living, the ones who respond to immunotherapy do very well even 4 or 5 years after the treatment. Sometimes we see complete responses. I would say there is a subset, small subset of the entire population, but whoever does well with immunotherapy, they go into fantastic responses, long-lasting responses. So the percentage of survival of non-small cell lung cancer stage 4, seeing the 5-year, it's up to about 20 or 25% now. So which is unprecedented.
That is a major change. And then what about, you mentioned melanoma as well.
Yeah. So even for melanomas, the survival, the 5-year survival has gone up for stage 4, has gone up from about 10% or less to about almost the same, 30 or 40%. And we are talking about even elderly patients doing well or going into complete sort of responses on immunotherapy.
For melanoma, is it more, does it need to be late stage melanoma? Can it or should it be used in early stage?
Some early stages, yes, especially when you have a high risk of recurrence. They have been trying immunotherapy as an adjuvant.
Okay.
So that doesn't relapse or recur.
Okay. What do patients need to be aware of, or what questions should they ask, and how can they make sure that they're getting the best treatment possible?
Yeah, so it's very important that they become their own advocates, So it's important when you have a diagnosis of cancer or your loved one, you do some research on the stage and type of cancer they have, and please go to authentic sites only, not Dr. Google.
Right.
Yeah, so we have some great websites like the NCI or the NHS or the cancer.gov, which is the ASCO site. So a lot of authentic cancer related websites. So go up and you have all the information you need to know about the type of cancer, the up-to-date information on the treatments available, and I recommend everybody go through that and then come and ask your doctor questions. And you're always entitled for a second opinion, so that's also important, to, especially when you have advanced cancer or some rare type of cancer or something that is not standard.
Well, it's good to know that immunotherapy is available right here in the Cayman Islands. And it's important, we've talked about this with another specialist as well, to be your own advocate and don't be afraid to ask those questions. Thank you so much for sharing this information and sharing with us immunotherapy and what a game changer it can be.
My pleasure. It's always very exciting. It's a very exciting time of the year to be here with the Cancer Society and its public health fair and all the other associated events. Always a pleasure.
Thank you, Dr. Vanitha. I'm here with Dr. Vivek Patel with Holy Cross Hospital, and we're going to be talking about innovations in radiation therapy. Thanks so much for being here with us and for visiting the Cayman Islands.
Absolutely. Thanks for having me in your beautiful home.
Now, tell me a little bit about, well, before we get into some of the innovations with radiation therapy, let's do a little bit of background. I know a lot of times when radiation is being used for treatment, that brings with it a whole other set of issues and side effects, right?
Yeah, absolutely. So even the name is a little bit intimidating, to say the least. When you hear radiation therapy, you think of, Chernobyl, you think of, different wars, et cetera. But really, when radiation therapy is not that intimidating. With modern technology, it's a very, very focal treatment with really very minimal side effects. So oftentimes we use radiation therapy along with surgery or along with chemotherapy or systemic therapy. So when we think of any sort of oncologic or cancer care, we think of basically a trimodality treatment. So the various modalities or methods are systemic therapy, which can be chemotherapy, hormonal therapy, immunotherapy, et cetera. You think of surgery, and then you think of radiation. And they all complement each other and are used in various facets of the care. Truly speaking, these days, since we have such targeted therapy, the side effects are really minimal just to the area that we're treating. So, if I'm going to treat a lung cancer, I don't expect any side effects apart from those that are in the thorax. So yes, patient can feel fatigued, have a little bit of potential sensation of soreness in the throat or a little bit of reflux sort of sensation, maybe a little bit of cough and shortness of breath that can be ameliorated with medication, but I don't expect headaches or burns or anything below the diaphragm, if you will. So
radiation has really come a long way then.
Absolutely.
Compared to when it was first used.
Absolutely.
Are there certain cancers that radiation is more commonly used for?
Yes, absolutely. So the most common cancer amongst men is prostate cancer. So we routinely use radiation therapy as a non-invasive way to treat prostate cancer. Not only are we able to minimize the side effects, there's less chance of impotence and less chance of incontinence with radiotherapy when you compare it to surgery, but we also have very, very similar rates of control. So in the United States, we follow the NCCN, which is a National Comprehensive Cancer Network, and the guidelines recommend for most prostate cancer that you can have radiation or surgery, so it's kind of an option. And other disease sites, for example, in breast, after a patient, which is the most common in women, of course, What we do is after surgery has been done, we give what we call adjuvant, which means after surgery radiation therapy, to the area where the surgery was to ensure that all the microscopic disease has basically been eradicated.
Okay. And what's new this year? What's new in 2019? What has really changed recently?
Yeah, absolutely. So I feel like all facets of medicine, all different fields in medicine are very quick to take on any innovation and technology, but radiation's even a bit more so. Am I speaking a little bit of bias? Sure, but objectively speaking, we usually work with linear accelerators, so just compared to all the other equipment that is used in other fields of medicine, it's very esoteric, but at the same time, we're using essentially space-age technology to treat our patients. So any sort of change that we can bring that will help give efficacy, meaning our ability to control and target the tumor and minimize dose to normal structures, we try to utilize that. So with that, we have different things such as intraoperative radiotherapy, which means right after surgery is done, we give a little bit of radiation to the postoperative bed where the tumor used to be. So that way, if there's any microscopic cells that the surgeon was not able to see or that cannot be removed, we can give radiation to that area. We also use different sorts of treatment with intensity modulated radiotherapy, so that way we're able to conform, which means give all the dose to the tumor while minimizing dose to the periphery. So that way, if, for example, somebody has a prostate cancer, we're worried about their bladder, we're about their rectum, their anus, the bones. Now I can give very, very minimal dose to those areas, which is below the threshold of injury to those structures, so that way there's less side effects overall, but while also effectively treating their prostate cancer.
Okay, so really good news in terms of what the outcomes are for
Absolutely.
these patients, right?
Absolutely.
All right, Dr. Patel, thank you so much for sharing this information with us. Thank you again for visiting the Cayman Islands. And this has been Dr. Vivek Patel with Holy Cross Hospital.
Thank you so much for having me.